Hey, what's going on? Happy BFR Tuesday. Hope everybody had a great Thanksgiving. And my name is Ed Cara. I am the Director of Education for Smart Tools, who manufactures the Smart Cuffs. And I jump on here every Tuesday at 1 p.m. Central to ask and answer any questions regarding BFR. Today, I will be sharing a little research regarding knee osteoarthritis and BFR. But I always like to start off these sessions with answering any questions that anybody might have. A lot of times people just jump on because they have a specific question and want to ask that. So I will start the first few minutes with kind of an open mic question and answer if anybody has anything for me. After a couple minutes, I will jump into what I wanted to talk about today. It's crazy masks. All right, any questions regarding BFR? One more minute, and if not, then I will jump into a study that I wanted to share. Hi, Manette. What's going on in the great Pacific Northwest? Probably just cold. Limb occlusion pressure on new cuffs higher than Gen 2. Is that accurate? Yes, it is. So we went to a slightly smaller cuff in the upper extremity, so you're going to notice higher pressures. Remember, cuff pressure is dependent on a lot of different things. The width of the cuff, the material of the cuff. So these new cuffs, this is a lower extremity cuff. And these cuffs are not as rigid as our first cuff. The first cuff, we put in a rigid liner, and why we did that, that's why they were like thicker. So you notice this is the new cuff, okay? And here's the equivalent old cuff. You can see the thickness difference in the two, kind of. You have to take my word for it. But these are much more rigid, much heavier. These are not going to give a ton, but they're a little bit more, they have a little bit more give to them. And then you have like an elastic that would require much, much more pressure. But the width is also going to be a determinant of how much pressure you need to find arterial occlusion pressure, or AOP. Also the size of the limb, meaning the circumference, like how big around is my arm or my leg, age of the individual. Morphology doesn't appear to be as big of a difference. Dr. Lonicki did a study looking at fat versus lean mass in a limb. Does it make a difference? It looks like it's more dependent on the actual size of the limb. So those are all going to play a part, and that's why we think it's so important to have individualized BFR, meaning I'm not just telling you what pressure to pump it up at. We're finding that limb occlusion pressure, either using a Doppler, external Doppler, or using something like our Gen 3 cuff that has the pump and the internal Doppler built in. So everybody has individual pressures, and individual pressures per limb, but also by body position. So standing is going to be a little bit higher than lying or sitting. So individualized pressures we think is important, and that's why we built in the Doppler and pump all in one. What else? That's all I can think of. All right, cool. If there's no other questions, then let's chat a little bit about what I wanted to share. So if you go to the handout, this is for us study 2017, looking at BFR and knee osteoarthritis. I'm going to share my screen. I've highlighted a few things that I think are kind of cool that people may want to take a look at, whether it's for themselves or clients that they're training. So, all right. I'm not sure what I can see and what I can't see. Okay. So this group looked at a 12-week supervised training program and assessed lower limb 1 rep max, quadricep cross-sectional area, functionality. And what they really wanted to see was, did this group of individuals increase in strength and size over this 12-week program? So some things that I highlighted. Number one is, this is a cool study because they looked at high intensity exercise, they looked at low intensity exercise, and they looked at low intensity with BFR. Now, what we're going to expect with most of these studies is, if the study is set up correctly, that we're going to find that the high intensity and the low intensity with BFR are going to have similar results. That's what I would expect. And the low intensity by itself probably not having much of an effect at all. Because what we know is that when we use light loads, unless we take those loads all the way to failure, we're not going to get adaptation by the body. But if we use light intensity with BFR, we will. So what they found here as a conclusion, blood flow restriction training and high intensity resistance training were similarly effective in increasing muscle strength, quad muscle mass, functionality in knee OA patients. Importantly, BFR was able to improve pain without inducing less joint stress, emerging as a feasible and effective therapeutic adjunct in OA management. And when we say adjunct, what other things do we do? I personally in the clinic use shockwave therapy, which has been shown to increase meniscus. I use dry needling within the quadricep. I sometimes use cupping. So a lot of different things that we can use from a pain standpoint and function of the muscle standpoint. But we know that there's a relationship between weakness in the quad and OA, and we need to increase the strength in the quadricep. So this is a great way to do it without overloading it. So we look at the patients, women between 50 and 65 years of age. High intensity, they did with 4 sets of 10 repetitions at 50% 1 rep max. So they call this high intensity, but this is really kind of moderate intensity, really. Whereas low intensity was performed 4 sets of 15 repetitions at 20% 1 rep max. So the low intensity, 20% to 35% is considering low intensity loading. 35 to 65% is really considered moderate intensity loading. So this is kind of falling more in the moderate. I wouldn't define this as high intensity, but you're trying to get those 10 repetitions in. With a low intensity group, the third group, they used a cuff that was 175 millimeters. For us Americans, this means nothing to us, but if I move the decimal over, this is 17.5 centimeters. Divide that by, what is it, 2.2 something, and that'll give us inches. So, you know, we're looking at right around a little over 5 inches, which we know is a wide cuff, something that would be considered like this, wider than 5 centimeters. The other thing they did here is they used continuous BFR. So there's 2 types of blood flow restriction. There's continuous and there's intermittent. Continuous means I keep the cuff inflated during the exercise. Intermittent means that I only inflate during my rest periods. So if I'm doing 30 repetitions and then I give a 30-second rest, I would deflate during the 30-second rest in intermittent. But with continuous, what they did here is they kept the cuff on. Now, because they were only doing 1 exercise, they did it throughout. They kept the cuff inflated and throughout rest period. But there wasn't a break between exercises because they didn't do a second exercise. Hopefully I was clear about that because it's a little confusing. So in normal protocol, we do 30 repetitions, take a 30-second rest, 15 repetitions, 30-second rest, 15 repetitions, 30-second rest, 15 repetitions. I then deflate the cuffs, move on to the next exercise, reinflate, perform the exercise in the same manner. Here, what they did is 4 sets of 10, or in the low intensity, 4 sets of 15, at 20% 1 rep max, but they kept the cuffs on the whole time. So this was considered continuous BFR. All right. What was really cool about this was patients' improvement in cross-sectional area and strength, which there believes to be a relationship between that and fall. You can look at pre-strength, post-strength, pretty dramatic, high intensity, low intensity, and then BFR. So pretty cool to see these changes with these light loads. Again, 50% is moderate, 20% is low. And so we know adding BFR to that will get changed. Now, this was a long study. This was 12 weeks. And these were untrained. If we look at the other thing that we need to look at is exclusion criteria, participation in physical exercise training over the past year. So we know that these people were untrained. Low intensity exercise still did not have an effect statistically. So we know low intensity exercise is not enough to cause adaptation, but if we add BFR to that low intensity, we will get a change. All right. So personally, I would never just do the one exercise. I would combine this with what I talked about last week, which was aerobic capacity. I would typically do 20 minutes of aerobic capacity training with the cuffs on the lower limb. I would then deflate. I would then reinflate and have them do 1 or 2 exercises for the quad and hamstring, quad, hamstring, calf, and really fatigue that out. And that's where we're going to see a good increase as well. We would just have to make sure we take a couple days of break in between, because if you're going to do that much work, then the body's going to require some rest. So if you are training at home, I would typically train 3 times a week for strength and hypertrophy with BFR, and give myself at least a day or 2 between days for recovery. All right. Any questions regarding that OA study? So download that, give it a whirl. Would be interesting to see changes over time. Oh, the other thing I forgot to mention, which I think was very important in this, I'm going to share this again, I'm sorry, was that they changed the 20% 1 rep max every 4 weeks by reassessing a patient's 1 rep max. So if you're only going to, do, 4, 8, 12 weeks of training, we need to be reassessing that 1 rep max with our patients, about every 4 weeks, and readjusting what weight we're using. Otherwise, we're not increasing incrementally, and then the percentage that we're using is going to be too low. So about every 4 weeks, I like to retest. Now, in the clinic, I typically don't get people for that long. I get people for 6 visits. And so I don't typically need to reassess, except for with my performance group. I like to reassess every month. So it's a little different depending on what type of population you're working with. If you're at home doing your own training, reassess that 1 rep max every 4 weeks and readjust your percentages based on that. All right. Would 3 to 5 rep max suffice? Yes, definitely. Minette, I would use an estimated 1 rep max. And so you could definitely use 3 to 5 and use the estimated chart that I've provided in the past to find that 1 rep max. And of course, if I'm a little light, I will let them continue until they get close to failure, 1 or 2 reps to failure, because that's where you're going to see the biggest benefit. What we're trying to do is estimate the weight that it's going to be required to get close to failure. And that's where you're going to see the benefit from, which is fatigue. All right, any other questions? All right, very cool. So thank you so much. I will, if you're seeing this as a replay and you want this study, I know the studies don't go out with the automatic email that goes with the replay. I'm happy to provide that for you. Just send me an email. And my email address is ed@edwardcara.com. All right, guys, thanks so much. Have a great week. I'll see you next week. Bye.